続いて渡辺先生、座長をお願いいたします。
それではですね、ここで吉川メモリアルレクチャーというものを始めたいと思います。で今日はその第1回目で最もふさわしい方ということではるばるメイヨークリニックからリック A 西村先生にお越しいただきました。で私たちってこのコアメンバーとか私も含めて近くにいた者はよく吉川先生のことを知っているんですけど、あまりご存じない方もいらっしゃると思うので簡単に紹介させてもらいます。じゃあスライド出してもらえますか。これ去年の東京ハートラボで吉川先生に座長をしていただいたところで去年お元気だったのが嘘のようですね。で次をお願いします。で実は吉川純一先生は神戸中央市民病院ですね、神戸ジェネラルホスピタルにエコーラボを最初に作ったんですよ。これはよく私たちが言われたのは、最初はトイレを改装したんやと、このお手洗いですね、レストルームからエコーラボに作り変えて、そこで彼はスタディを始めました。次お願いします。でいろんなものを作ったんですが、1990年にはアメリカン・ソサエティブ・エコー・カーディオグラフィーに先立って日本のジャパニーズ・ソサエティ・オブ・エコー・カーディオグラフィーを作っています。次お願いします。で2003年にはメイヨークリニックからパイオニアアワードというのを受賞されていらっしゃいます。次お願いします。で常にですね海外、国内外を問わず、友人や先生を求めて一歩外に出ようと、そして国際交流を含めたそんな中からですね、たくさんのことを学べということを示されています。でこれでいいのかな、こちらにいらっしゃるのがリック先生ですね。タジック先生とか名誉の主要なメンバーの先生がこちらにいらっしゃって、吉川先生もいらっしゃいます。じゃあここでじゃあリック could you come up to the stage? Today we have a world famous great guest, Professor Rick Nishimura, for Dr. Yoshikawa's Memorial Lecture. Rick came here all the way from Mayo Clinic in Minnesota, United States. Rick is one of the leaders of cardiology and always inspires diagnosis and treatment approach, especially valvular heart disease. Rick has been the best friend of Dr. Yoshikawa. And Dr. Yoshikawa is a pioneer of echocardiographic field and has supported this meeting for a long time. So we think the Rick is the best person for Dr. Yoshikawa's memorial lecture. Rick, please get started your lecture.
Thank you very much. I want to first say that it really is an honor to present the Yoshikawa lecture. At the American College of Cardiology, we have used the term legends for the most famous cardiologists in the world. And Professor Yoshikawa has certainly fulfilled the criteria for a legend, which is the most important and famous person in the area, and that is the area of echocardiography. Not only did he have the enthusiasm and the intelligence and the drive to put forth the Japanese Society of Echocardiography, but he had the insight to bring people from all over the world. And this is my own mentor, Professor Jamil Tajik, who he and Professor Yoshikawa actually created much of echocardiography, from which we've learned from them. Now, it was my pleasure actually to work with Professor Yoshikawa, and one of the greatest things that I ever was able to accomplish was we got together one day and decided to write a book. And this was my only book in Nihongo, but in the side, the cover was a nice little memo from Professor Yoshikawa that the book was made to improve the friendship, and we are going to miss him very much. But I think the thing that most of us remember about Professor Yoshikawa was not only his scientific drive and discovery, but his laughter and his humor and his ability to make everybody feel welcome. So again, it's a great pleasure to be able to present this lectureship. Now let's turn to mitral regurgitation. And I've been asked to speak about the treatment, past, present, and future. And the only thing I'll say about the past is that when we first started to write the American guidelines in 1996, it was relatively easy to determine when to operate on a patient with mitral regurgitation because all we had was insertion of a prosthetic valve. And at that time, the operative risk was high, 5 to 8% in-hospital mortality. And as we all knew, these prosthetic valves had significant complications in the future of thromboembolic events, bleeding, and infection. And so at that time, we said the indication for operation was severe New York Heart Association class 3 or 4 symptoms. Now, what's happened over the decades is we've learned about the pathophysiology, we've learned about the natural history, and we've learned that we have much better treatments. And because of that, what we'll go into over the next few minutes is that the indication for operation consists of lower and lower thresholds so that we can indeed prevent the irreversible consequences of long-standing volume overload. And I think our future is ripe in that the surgeons are getting less invasive and better operations, but from the interventional standpoint, we have less and less invasive treatments. And as soon as we are able to perfect the percutaneous mitral valve, the entire scene will change in terms of our timing of intervention for the treatment of mitral regurgitation. Now, as Dr. Abe was pointing out, we've got 2 different types of mitral regurgitation. So that when you are seeing a patient with mitral regurgitation, you have to remember to divide them into primary, which is a disease of the valve, and secondary, which is a disease of the ventricle. They are 2 different diseases. They should be evaluated 2 different ways, and their treatment is completely different from each other. Now, for primary mitral regurgitation, the most common, I think, in both our countries is the degenerative mitral valve prolapse, Barlow's disease, or fibroelastic deficiency. Secondary, we'll talk about somewhat about the dilated, but mainly about the patient with the ischemic mitral regurgitation. Now, let's first turn to the patient with primary mitral regurgitation, a disease of the valve. In these patients, they present a problem. And we've known for decades that regurgitant lesions present a problem. And the reason they present a problem is because long-standing volume overload can cause left ventricular dysfunction. But left ventricular dysfunction can occur before the onset of symptoms. So by the time the patient becomes symptomatic, left ventricular dysfunction may have already occurred despite the fact that we have been following them with echocardiography. And if you think about the concept of volume overload, there is the onset of severe regurgitation, but there are many, many years, even decades, as nothing happens to the patient except progressive left ventricular dilatation. At some point in time, that long-standing volume overload is going to cause incipient left ventricular dysfunction, and because of the loads on the left ventricle, the decrease in preload and the increase in preload and the decrease in afterload, one's ejection fraction might not necessarily drop while left ventricular dysfunction is already occurring. And finally, after the onset of left ventricular dysfunction, one will have symptoms, but by the time symptoms develop, the prognosis is very, very poor. So we have had problems in identifying patients who are candidates for operation, because if we wait for symptoms to occur, we have problems. Once there are symptoms or left ventricular dysfunction, the prognosis is dismal. We also know that if we have severe mitral regurgitation, primary mitral regurgitation, if left untreated, the prognosis is very, very poor in that at 10 years' time, 6 out of 10 will have developed heart failure, 8 out of 10 will require surgery, and 9 out of 10 patients who start out with severe mitral regurgitation will either need to undergo surgery or die. So we would like to be able to intervene on these patients sooner, but we're not able to in the past because we did not have good interventions with the mitral valve prosthesis. Now, fortunately, we now have mitral valve repair. It has completely changed the way that we look at a patient with primary mitral regurgitation. And as you saw this morning, from the excellent surgical centers, primary mitral regurgitation should be able to be repaired with a greater than 90 to 95% certainty if the mitral valve anatomy is suitable, and the operative risk should be less than 1%. Much, much different from what we had in the past with a mitral valve replacement. And we finally now have data about early operation, about operating on these patients before they become symptomatic, before their left ventricle fails. And this is just a survival curve that Rakesh Suri, one of our surgeons, put together that shows the outcome of patients who undergo early surgery for severe mitral regurgitation before the onset of symptoms, before the onset of left ventricular dysfunction, compared to those patients who have medical management. And there is a concept that some other institutions have of what's called watchful waiting, and waiting till the left ventricle starts to dilate or deteriorate. But as is evident here, if we wait, it is too late. And thus there is a survival benefit that has clearly been shown now in the hands of excellent surgeons with operating on primary mitral regurgitation before the onset of symptoms, before the onset of left ventricular dysfunction. So if we think of what we had in the past in this curve of survival on the y-axis and the x-axis is the years that we follow, we used to wait for the onset of symptoms. Once the onset of symptoms is there, certainly they're better with an operation than if left unoperated upon, but their prognosis has already started to deteriorate because they have left ventricular dysfunction. If you wait for left ventricular dysfunction, you do better than waiting for symptoms, i.e., when the ejection fraction starts to drop less than 60% or end systolic dimension is greater than 40 millimeter. But the ideal time to operate is before the onset of symptoms and before the onset of left ventricular dysfunction. So as opposed to what we used to do 10 years ago or 20 years ago, in patients with primary mitral regurgitation, it's reasonable to consider operation if, number one, it's truly severe mitral regurgitation. So you need your quantitative measurements of effective orifice area and regurgitant volume and regurgitant fraction. If you have surgeons who can do the operation with a low operative risk of less than 1 to 2%, and if you know that your surgeon is capable of repairing the valve with a greater than 90 to 95% chance of successful repair, a durable repair, the patient is much better off with early operation versus watchful waiting. So again, with primary mitral regurgitation, which is a disease of the valve, the indications for operation are, number one, symptoms. So a symptomatic patient should certainly be operated upon. But you'd like to get them before the onset of symptoms. So if they're asymptomatic, but they have left ventricular dysfunction, Their ejection fraction is starting to deteriorate. They will do better with operation than without operation. But you will help all of your patients out if you identify the patient with severe mitral regurgitation before the onset of symptoms, before the onset of left ventricular dysfunction, and have your surgeon who can do a successful mitral valve repair do the early operation instead of watchful waiting, and overall their outcome of these patients is comparable to that of an age-matched, sex-matched control population. So what we've done over the years is significantly decrease the threshold for operation for primary mitral regurgitation. Now, Dr. Abe spoke about secondary mitral regurgitation. Secondary mitral regurgitation is more controversial, difficult to understand what to do, because this is not a disease of the valve. This is a disease of the left ventricle. We have the dilated ventricle. I want to spend the next few minutes talking primarily about the ischemic ventricle, because that is the one in which we have the most difficulty. Now, ischemic mitral regurgitation, as Dr. Abe said, is a disease of the left ventricle. The valve morphology itself is normal. But what happens in these patients who have ischemia or infarction, primarily in the inferolateral distribution, is you have leaflet tenting, you have a tethered posterior leaflet due to the akinetic posterior medial papillary muscle and hypokinetic inferior wall, and that then results in a jet of posteriorly directed mitral regurgitation. Now, this ischemic mitral regurgitation is sometimes very, very difficult to evaluate. It is very dynamic, and this is just a cardiac catheterization of a patient who came to the catheterization laboratory looking at the left ventricular and wedge pressure at rest. But then what happens is the patient gets onset of ischemia, and suddenly the mitral regurgitation goes from mild to moderate to severe with a large V wave up to 70 millimeter of mercury and pulmonary edema. So it's not just the resting state that you need to evaluate these patients, but what happens during their daily activity. We know ischemic mitral regurgitation is very common. It actually occurs in over 40% of patients following a myocardial infarction, and has been shown earlier the outcomes once there is ischemic mitral regurgitation in those patients with ischemic heart disease is poor. The mortality is double if ischemic mitral regurgitation is present, and if in fact you have severe mitral regurgitation, the survival is approximately 40 to 45%. Now the problem is we are unsure about how to treat these patients with ischemic mitral regurgitation. We know that all patients should have aggressive medical therapy for the left ventricle. And we know that if possible, we should treat the ischemia. But what we don't know is if, when, and how to treat the mitral regurgitation itself. This is different from primary mitral regurgitation. The mitral valve operation can either be a replacement, a repair, or a percutaneous clip. But the difference lies in this, is the left ventricle being the primary disease, no matter what you do with the mitral regurgitation, may actually remodel adversely and progress in terms of the abnormal tethering on the mitral valve leaflets. Many times a repair has been done, and even though in the operating room the repair looks like it's very viable, it is not necessarily durable, and mitral regurgitation may recur and recur. And as was said before, we really do not have data on improved outcomes by intervening on the mitral valve itself. Medical treatment, all patients should undergo. It's a disease of the ventricle. We treat the left ventricle. with angiotensin converting enzyme inhibitors. We treat them with beta blockers. We know now that aldosterone antagonists are very, very good in preventing the adverse interstitial fibrosis that occurs in these patients. If there's hibernating myocardium, you're going to try to treat the ischemia to improve ventricular function. And if there's a wide QRS complex, this even might require resynchronization. But all patients with secondary mitral regurgitation should always undergo guideline-directed medical therapy for the left ventricle before even contemplating anything else. Now, as far as treatment of the ischemia, it's very, very complicated, and Dr. Abe has some very, very good recommendations on what to do with some of these people, and I certainly like the idea of the low-dose dobutamine to help determine what happens with ischemia and treatment of the ischemia. But I thought what I would do is put things together in a simplistic approach to think about in these patients with ischemic mitral regurgitation, in that you're going to have a set of patients who are undergoing revascularization for their ischemia. And you have to think of those separately from the group of patients who will not be undergoing revascularization for ischemia. They are two different groups of patients, two different types of therapies, two pathophysiologic processes. Now let's take the patients on the left, those patients with ischemic mitral regurgitation who are going to undergo revascularization either with catheter-based therapy or coronary bypass grafting. We should divide those into patients who have moderate mitral regurgitation and patients who have severe mitral regurgitation, and then discuss what data we have in terms of repair versus no repair for moderate and repair versus replacement for severe. Now, Dr. Abe has already presented some data that we have. For the first time in valvular heart disease, we actually now have randomized trials from the CTSN network that the National Institutes of Health has sponsored. Randomized trials that we never had before in valvular heart disease. We now have that for TAVR, we have it for MitraClip, and now we have it for surgery for the mitral valve. And one of the first randomized trials that came out was the trial that looked at moderate mitral regurgitation in patients already undergoing coronary bypass grafting, because there was equipoise as to whether or not you would perform a repair with less residual mitral regurgitation or leave the mitral valve alone and let the ischemia, the treatment of the ischemia, take care of mitral regurgitation and thus have a lower operative risk. And the 2-year follow-up was just recently published on this, a follow-up after the 1-year follow-up. Residual moderate mitral regurgitation was seen in 30% without repair versus 11% in the repair, but the repair group had much higher incidence of postoperative complications. And if you look at the outcome, the clinical outcome in death, functional status, or quality of life, there was no significant difference between those patients who underwent repair versus no repair, aside from the fact that those patients who had repair had higher perioperative complications. The next randomized trial looked at those patients who had severe ischemic mitral regurgitation, because the question always arose is, should the surgeon try to repair those valves or simply replace the valve? And the repair with a restrictive mitral valve might have a lower perioperative risk, but chordal sparing mitral valve replacement might have better long-term outcome, because repair might not always be a durable repair. And again, the 2-year outcomes were just recently published of this randomized trial of repair or no repair. It turns out that of those patients with severe mitral regurgitation with ischemia from ischemic cardiomyopathy who underwent replacement, the recurrent rate of mitral regurgitation was less than 5%. Those who underwent repair, the operative risk was higher, and the recurrence rate of mitral regurgitation was greater than 50%. There was no difference in overall mortality, but the repair group had a higher rate of heart failure, higher incidence of hospitalization 1 to 2 years following the study. Now, there are caveats with the mitral valve repair in this study because the surgeons only use an undersized annular ring. And I know that you have some very excellent surgeons here in Japan who are able to do much more with the repair. And if in fact you have highly experienced surgeons who can do other interventions such as papillary muscle relocation, chordal cutting, papillary muscle slings, sandwiches, cut and transfer techniques, you might actually get a much more durable repair than was done with an undersized annular ring. So I think in putting all this together for ischemic mitral regurgitation, as we look to the left in patients who are undergoing revascularization, for those with moderate mitral regurgitation, I like the idea of using dobutamine to help out, but at this point in time, in the United States, most of our surgeons are leaving the mitral regurgitation alone because correcting the ischemia is going to correct the mitral regurgitation in the majority of patients. In those patients who have severe mitral regurgitation, most surgeons will go to mitral valve replacement, but there are some patients who do not have an inferral basal aneurysm, who do not have severe tenting, in whom a surgeon can do a more extensive repair, and in those patients a repair might well be worthwhile if a durable repair can be performed. Now on the right-hand side are patients who have severe mitral regurgitation from ischemic etiology but are not candidates for revascularization. They present mainly with heart failure from their left ventricular dysfunction and their mitral regurgitation. In those patients, again, guideline-directed medical therapy is of utmost importance, and one should not consider any intervention until they've had optimal guideline medical therapy. Many of them actually will improve both in their symptoms and their left ventricle and their mitral regurgitation. But if they have continued severe symptoms despite optimal guideline-directed medical therapy, mitral valve intervention might be appropriate, and if so, these are the patients, those patients who present primarily with heart failure in whom mitral valve replacement is better than mitral valve repair. Now, the future of the treatment of mitral regurgitation is very, very exciting. The surgeons are getting better and better. Their operative risk is getting lower and lower. Their long-term outcomes are getting better and better. And many across our country are using the less invasive approaches, the minimally invasive thoracotomies, as well as the robotic procedures. And the outcomes of a robotic approach are very comparable to that of the full sternotomy in the hands of experienced surgeons. From the interventional standpoint, the mitral clip has been the primary catheter-based therapy that everyone is using for mitral regurgitation. As was shown, it creates an Alfieri-type stitch. Now, the data, though, is controversial for the mitral clip. We know that in patients who have primary mitral regurgitation, if they're at high risk for surgery and they have severe symptoms, it's very reasonable to perform a mitral clip. However, you have to understand that after a mitral clip, the majority of patients will still have a residual mitral regurgitation of 2+ or more. So if these patients are otherwise candidates for operation, they get an operation. And the only ones at Mayo Clinic who will get a mitral clip are those who are deemed too high risk for surgical intervention. Now, secondary mitral regurgitation due to ischemic etiology or mitral regurgitation due to a dilated cardiomyopathy, certainly these patients are at increased risk for surgery. But we don't know if correcting the mitral regurgitation does any good. So we are not doing MitraClip for secondary mitral regurgitation, but instead enrolling these patients into a randomized trial. The results of the randomized trial will be available in the next year, and we will then know whether or not this would be appropriate for excuse me, secondary mitral regurgitation. Now, the clip is not that effective because it only does the leaflet, and a good surgeon will always do an annuloplasty ring. So what we are looking forward to is the future of mitral regurgitation treatment, and that is the percutaneous mitral valve. And currently there are 15 different percutaneous valves being tested right now. The problem is the seating of the valve and the durability of the valve. Right now, percutaneous mitral valve replacement is not ready, but when it is, as with TAVR, it will dramatically change the way we treat these patients. So what I wanted to talk about was the treatment of mitral regurgitation, the past, the present, and the future. And there's a bright future ahead as the surgeons get better and better, and as we get more and more catheter-based technology, and I'll be anxious to see what happens over the next 4 to 5 years. But again, I want to reiterate that this was the Yoshikawa Memorial Lecture. Again, this is Professor Yoshikawa with my mentor, Jamil Tajik, and together they revolutionized the field of echocardiography, and I'm very appreciative for what he has done. Thank you very much for your attention.
Thank you very much, Professor Nishimura, and thank you for the beautiful lecture for us. And could you mind accept some question?
Sure.
Okay. ではせっかくの機会ですので、どなたかもう少し会場を明るくしていただけますか。質問を。はい、で柴山先生どうぞ。
Thank you, Dr. Nishimura. Very beautiful lecture. And my question is, do you think atrial function MR is secondary MR? Because the mechanism is different from DCMR, ischemic MR.
Yeah.
Maybe a component type 1 and type 3B with preserved EF.
Yes. You know, when I heard you speak about this, I was very pleased because for years and years and years, we have said that atrial fibrillation can cause progressive mitral regurgitation and tricuspid regurgitation and to be the primary cause of the heart failure in all of these patients. I actually don't know whether or not it's a primary or secondary mitral regurgitation. I look forward to seeing further results of the surgery that's being done because I think that is indeed the only thing to do if we can't get a patient back to normal sinus rhythm. But there is an emerging epidemic in the United States now of patients with severe mitral regurgitation and tricuspid regurgitation due to atrial fibrillation, and we need to further understand its mechanism. I enjoy your question. I can't answer it right now, but I can tell you that in the next couple of years, we are going to be studying this very, very carefully.
Thank you.
はい。安倍先生。
Thank you very much for your excellent overview, excellent lecture. And I was very surprised that you called my name in your lecture. So, I counted that you
5
called
times.
maybe 6. Thank you very much. I am very interested in functional MRO, but can I may I turn the subject to primary MR?
Yes.
Okay. So, how should we treat with the patient just after the onset of primary MR? So, it sounds you recommend early surgery, but if that patient has severe MR, but just after the onset, and no symptom, no LV or LA dilatation, but he goes to good hospital. That hospital has very good surgeon. So
I am very happy that you asked that question. We have a number of patients who come to Mayo Clinic for mitral valve operation who have what you have. They say there's severe mitral regurgitation, primary mitral regurgitation, but the left ventricle is normal size and the left atrium is not dilated. They can't have severe mitral regurgitation. Volumetrically, it cannot occur. You cannot have 50% of the volume of the left ventricle go back to the left atrium and have a normal sized left ventricle. So if these patients have diameters of 48, 49 millimeter, even though the echo criteria says it's severe, it's not volumetrically severe. And we actually see that a lot in patients with mitral valve prolapse who have late systolic jets. And you listen on auscultation. We were talking about the clinical examination. It's incredibly important because if they don't have a holosystolic murmur, it means that their chordal their chordae are intact and all they have is the prolapse. And they all have the prolapse and the regurgitation only happens in mid to late systole. The total volume, despite all of our measurements, is not enough to cause severe mitral regurgitation. So to me, severe mitral regurgitation means a volume overload on the left ventricle. And if you have a normal left ventricle, especially with the normal left atrium, it is not severe. This is very, very important, and we have tried to emphasize this again and again in all of our papers and guidelines. But this mid to late systolic mitral regurgitation that people say is severe is not severe as your left ventricle is normal. So the answer to your question is one group that I took some time because one group that you have to be aware of is that group that says they're severe but the left ventricle is normal.
Okay, so we can select careful watching till the LV dysfunction appears.
Not LV dysfunction. So
dilatation.
Well, yeah. So yeah. So if you wait till left ventricular dysfunction, ejection fraction less than 60%, you've waited too long. But if the ventricle starts to dilate, then you need to intervene.
Thank you.
Thank you very much for that question.
その他ご質問いかがですか。はい、大門先生。
Thank you so much for your excellent lecture. And as you show in your slide, your presentation, all of us are so disappointed the result that was shown in the previous studies that examined the operative result for functional MR. But one of the major limitations in this study was, I think, they selected the patient only by the severity at rest. I mean, as you know, so I'd like to ask you about the utility of exercise echocardiography for selecting the patient with functional MR.
Yeah. No, I agree entirely that we make a mistake many times by writing guidelines based upon one measurement at rest, when the patient is in their daily activity experiencing a different hemodynamic milieu. As they exercise, their blood pressure gets up, their ventricle might dilate, so on and so forth. So I am a strong proponent in my patients to always exercise them and look at the hemodynamics with exercise. I think it makes a lot of physiologic sense, and I would very, very much recommend it.
Thank you.
じゃあ、そろそろこのセッションを締めたいと思います。Now we have to close this session. Thank you very much for your lecture.
Thank you.